Check. Hey. Connect. Ah. Okay. Good afternoon, everyone. Good afternoon. I need to hear good afternoon. Good afternoon. Okay, okay. Please make sure that you don't sleep. Please make sure that you don't look into the phone. If I catch you, probably I'll ask you to come here and do some exercises. Okay, so be attentive. If not, now only you can escape. Okay, very important topic. Am I audible? Very, very important topic. A lot of challenges we face while treating athletes with shoulder pain. So let's see. Yeah. So the overhead athlete's shoulder, current concepts and challenges. So humans, if we can throw what humans can throw, apes and other animals or something, they can't throw the velocity or the pace with which we are throwing. So humans are definitely have a high precision and high capacity, high strength in order to throw certain objects with a particular velocity. Okay, and we have evolved from apes. So initially we were struggling to use our weapons to hunt animals, but eventually we evolved and look at that, we became a little more stronger and then we are able to, throw better. And that strength and that evolution we incorporate in sports recently. So if you compare the scapula position between the humans and the monkeys, there is a lot of difference. So the orientation of the scapula is, look at that, on the right side it is the scapular orientation. And whenever the monkeys or apes try to hold on to something or to perform some activity, their orientation is above 90 degrees, whereas humans, whenever we involve in throwing something, it is always below 90 degrees. And look at the orientation of the pectorals. Okay, so for apes, the orientation of the pectorals is a little more superior in order to accommodate the upward rotated scapula, whereas in humans, the sternal fibers of the clavicle or the sternal fibers of the pectorals are oriented horizontally. If you compare the right and the left was the pectoral major of the humans and the right was the pectoralis major of apes, chimpanzees. And this is the orientation. The right was the orientation of the scapula in apes, whereas the left, it is the orientation of the scapula in humans. So what humans can do, what humans can't do. Humans can throw any object with a greater velocity. And the velocity with which they throw, for example, if it is a baseball, if you take, the velocity is almost 170 kilometer per hour. Unimaginable, isn't it? And if you ask any other animals which are close to humans, they won't be able to do this. Okay? But what we can't do is, we can't hang on to, bark of the trees, or we can't hang, or we'll say it is a brachiating. So we won't be able to do brachiating if you compare the left and the right picture, whereas the apes can easily brachiate better. And then they swing from one place to other place for the branches of the trees. So what helps in that? The evolution has helped in that. The evolution of the human shoulder, it has helped us in order to perform a particular sport related higher velocity with precision, so that we can involve in a lot of sports. So this is the orientation of the scapula of the chimpanzee, left side, and right side is the orientation of the scapula of a human being, right now, after evolution. So if you see the ribs of humans, right now it is barrel shaped for us, whereas it was almost triangle in terms before, probably millions of years ago. It was triangle when we were evolving, and now we have a barrel shaped chest, which helps us in producing a lot of shoulder movements. So look at this. So what is that? The red color, if you see, the house painters, they tend to get a lot of shoulder pain when they involve in specific activities for more than 12 months. Because these painters, most of the time, they end up in activity, and after the hitting the ball, it is deceleration. So there are three phases. So one is preparatory, where he starts from the beginning, as soon as he initiates the movement, till he reaches maximum external rotation. That is a preparatory phase, followed by your acceleration phase. He accelerates from maximally external rotation position to internal rotation position. So this movement is very significant for shoulder movements and any overhead shoulder activities. Okay, and at last you end up in deceleration movement. So these are the three phases which are key in determining a better overhead sporting activity. Okay, so can anyone tell me how much force will be generated from the shoulder if you are hitting a tennis serve or if you are hitting a badminton smash? What do you think? How much force can be generated? What contribution of force will be by the shoulder when you do a tennis serve? Yes, guess. 80%, 70%, 60%, whatever it is. How much percentage do you think? Should I come down? How much percentage do you think a shoulder can contribute to? Yes, read two. Yeah. Guess. No idea. No, guess. 80% of force is generated from the shoulder. That's what his argument. Anyone from here? Guess. Only I will hear. You can tell me. Yeah. Issue with the pelvis or the lower limb. The issue with the pelvis or the lower limb, that might get transmitted to the shoulder. So your shoulder has to work too much in order to produce force. Eventually what happens? A lot of micro trauma happens and you will end up in injury. Getting it? So in this case, if someone comes to you with a shoulder pain, will you treat only the shoulder or you will treat it as a whole, as a movement system? What do you think? Because shoulder is contributing only 20% of the force. That means somewhere, the source of pain is somewhere, the source of the problem is somewhere, because of which you are getting issues in the shoulder. So instead of looking only at the shoulder, you have to look it as a whole movement system and then focus on improving the strength. Okay, so focusing only on the shoulder in order to treat the shoulder pain is not a great idea. You have to look into the whole system, treat it as a movement. So that is what we say is a kinetic chain. Okay, if you see this, look at the orientation of the pelvis, look at the force generated from the legs, from the pelvis, which gets transmitted to the, finally to the javelin. So it needs the entire kinetic chain to work, and it has to work in a sequence, and then it has to generate it to the, it has to be transferred to the shoulder. So if you see here, in both the late cocking phase, which is in external rotated position, and in the just before the release phase, again it is an external rotation, which is a crucial part. Okay? So the critical moments, late cocking phase and early deceleration phase. So these two phases are the crucial phase. So if someone, cricketer, comes to you saying that I have shoulder pain when I throw from boundary line, basically you might have to look at his throwing mechanics in order to understand exactly what happens. Okay? So just by treating the shoulder, what will you generally give? Your electrotherapy modalities or your whatever mobilization focusing only on the shoulder. Is it going to help? Yes or no? Yes or no? Is it going to help if you focus only on the shoulder? Definitely no, isn't it? So you have to focus on both the shoulder as well as the entire kinetic chain. Clear? Okay. So there are so many challenges we face. Relevance of clinical assessment. Now this you have to tell. What clinical assessment do you do whenever there is a shoulder pain? Tell one example, special test. Yes. What is a special test you know? 2, 3 special tests you tell me. Yeah, she wants to tell, yes. Special test for the shoulder. Anything? Empty can test. Very good. Okay, which college? IP, okay, something, okay. So she said empty can test. Do you do empty can test? Okay, any other test? Any other test do you do? Tell. So much you study in 4 years, isn't it? So empty can test, full can test. If empty is there, full is also there. Full can test. Anything from that college? Should I come there? Tell before I come there. One test. Hawkins Kennedy test. No? That's a new test. What are they saying? With this, I couldn't hear anything. Can't hear. Knees impingement. Okay. Okay, I don't know. Okay, there are hundreds of tests are there. Everyone will do a lot of tests, but that is the biggest challenge while doing it. What is the relevance of, where are the symptoms coming from? It could be a psychological factor. It could be a stiff shoulder, frozen shoulder, osteoarthritis, dislocation, instability. It could be osteosarcoma, posture related, hypermobility, hypomobility. So many things are there, central sensitization. But usually shoulder pain comes as a combination. So everything, it is multifactorial. Okay, many factors contribute to shoulder pain. So treating only one part, for example, stiff shoulder. So if you see working only on the stiff shoulder, will you be able to get 100% result? Definitely no. So you have to look into the multifactorial aspects in order to work on that. Yeah, new college is going to join and they're going to answer. Next. Okay, so the basically, so the basic issue is this. So first we'll sit and discuss with the patient what is the issue and how do we rectify it? How do we proceed with that? Second problem is outcome measures. We take some outcomes, PADI, DASH, okay? His functional ability can be checked, okay? So that you will check. And then finally, impairments, how much impairment the person has, you will do. But the problem is this, imaging, specific orthopedic test. Do you do ultrasound? Do you check MRI? You guys check MRI? MRI reports shows that there is a impingement. Do you do that? Gone. I'll tell you what is that. So, but the problem with this special orthopedic test and imaging, there are two issues. Okay, so let's see this special orthopedic test. So we have got a lot of tests. They have introduced some new tests as well. That's wonderful to hear that. And these people said some knees test and can test, empty can, full can, whatever it is. But what about the what is the evidence says about that? A review of the special tests associated with the shoulder examination, rotator cuff test, all these knee impingement, Hawkins, and rotator cuff tests, so many are there, yeah? Hundreds of tests are there. So what exactly you get is these special tests are not special, okay? Actually it can provocate pain, but it doesn't show which structure is involved. So there is no point in doing all these tests in the future, okay? So if someone asks, or if someone sends you a patient saying that knees test is positive, this test is positive, that test is positive, don't believe in that. It might not work, yeah? Because you can't completely say that this test is positive, so only that structure is involved. No, because the anatomy is different. How is that different? So can test. What they said is empty can, easy, full can, So in this, you can't isolately activate any test. So the empty can and full can test do not selectively activate supraspinatus. We always say supraspinatus tendinitis, tendinosis, tendinopathy, whatever it is there. We always say that empty can is positive, full can is positive, we'll say supraspinatus impingement. But it is not so. Okay? So these tests do not satisfy basic criteria and not a great valid test. It is not a diagnostic tool for tests. Okay? She's so happy. So what is your take home message from this? You won't do, what is the take home message? Black t-shirt. Yeah, yawning, black t-shirt, yeah. Black shirt. What is the take home message? You won't do special test. Let your professor teach us lot of special tests, but it is not relevant. You can tell them that it is not relevant to test that because you can't isolate only one structure through your special test. Clear? That's the take home message. Okay. So this is the anatomy. This is the subscapularis. What are the rotator cuff muscles? What are rotator cuff muscles? We speak so much about rotator cuff tendinopathy, but what is rotator cuff? What are the rotator cuff muscles? Supraspinatus, infraspinatus, teres minor and subscapularis. Those are the muscles. But do you think, is there any difference in that? Everything is connected, isn't it? So, because the anatomy is like this, it is impossible to separate or differential diagnose that which segment is affected or which tendon is affected by using your special test. Clear? That's the take home message. No more special test for the shoulder. Clear? If you go home with that mentality, my work is done. No more special tests because none of the special test is going to identify your source of pain. Because everything is interconnected. You can't isolate one structure. Clear? Okay. So next, so the tendons were found to splay out and it interdigitates between together. Everything is interconnected. So you can't structurally differentiate these tendons. Done? So first challenge is what? You can't make a definitive clinical diagnosis. Clear? First take home message. Second one, imaging. Shoulder pain, go get an MRI. Go get a ultrasound done. Now let's see what is the evidence says. Prevalence and risk factors of rotator cuff tests. So what they did, like this group of people who are talking, who are sleeping, they will take 283 people they have taken, and in that 65% with rotator cuff tests had no pain. Means what? They will randomly take people and then they have checked the ultrasound. None of them had rotator cuff tests. None of them had rotator cuff tear symptoms. They have no pain, but they had rotator cuff tear. 65%. Okay, take home message 2. So asymptomatic rotator cuff tears. So many people are having, they're asymptomatic, no issues. I don't have any problem with the shoulders. Taken ultrasound, lot of tear. This impingement, that tear is there. Full thickness tear, half thickness, partial thickness tear. So almost 40% of the people have asymptomatic partial tear of the tendon. Ultrasound scan, asymptomatic shoulder abnormalities were found in 96% of the participants. 96% of the participants. Tear is there, but there is no, the ultrasound shows tear, but there is no symptoms. Take home message, important. Now, okay, leave ultrasound. Let's go to the MRI. What does MRI say? So they have taken subjects with subacromial impingement syndrome and then the subjects without subacromial impingement syndrome. And in that control group, for example, asymptomatic group like you, almost 52% had rotator cuff pathology. Normal people like you and me who doesn't have any problem with the shoulder, but when they just do an MRI, they found that there is 50% of us had issues. So what is the take home message here? Imaging can't exactly reveal the source of pain. Understood? So first challenge is what? What is the take home message? First one, what is that? Clinical diagnosis. Your special test is not very special to structurally differentiate. Number one. Second one, your MRI and the symptoms and the pain, there is no correlation at all. So don't completely rely on the imaging. Don't completely rely on ultrasound or MRI. Take home message 2. Now 3. Posture related. Posture is some people are kyphotic, some people are excessive lordotic, and people will think, okay, you have an excessive kyphotic posture, your shoulder pain is because of the kyphosis. That is a usual tendency we tend to develop. Okay, it may not be right. Okay, what evidence is? No evidence to support the scapular posture, and we are. Have you heard of this scapular dyskinesis? Scapular dyskinesis. What do you understand by scapular dyskinesis? Position or the movement of the scapula, abnormal movement of the or abnormal positioning of the scapula. We think that these scapular dyskinesis you will end up in. If you have scapular dyskinesis, you will end up in shoulder pain, but it is not so. What do you understand by scapulohumeral rhythm? Yes, he's very happy. What is scapulohumeral rhythm? So much you spend time to understand that. What is that? 1 point. What ratio? 2:1 ratio. But who told you that? Your professor told, right? The professor has read in something else. Okay, what he has read is this 1944 paper saying that the scapulohumeral rhythm is 2:1. Means what? The scapula contributes 1 degree of movement. For every 1 degree of scapular movements, the glenohumeral joint contributes 2 degree of movements. We learnt it, isn't it? But this may not be right, because where they derived this from? They derived this from 1944 article. What they say? So they had one patient, one normal person, okay, and then they have analyzed, and based on his scapulohumeral rhythm, they found that it is a 2:1 ratio. So just because of one person, can we confirm that scapulohumeral rhythm is 2:1? No. So we learnt it wrong. We need to unlearn it and we need to relearn it. Yeah. So if someone asks about scapulohumeral rhythm, you say the entire scapulohumeral rhythm is based on one study on one subject. So it can't be reliable. Okay, remember that. And the rhythm changes with respect to different things. For example, if you use a heavy load, the rhythm is different. For age, rhythm is different. For left and right, rhythm is different. What did I say? What am I speaking about? Scapular dyskinesis, scapulohumeral rhythm. Yeah, it is different from person to person. Clear? What scapulohumeral rhythm? You might have 2:1 ratio. I don't have, but both are asymptomatic. Okay, so you may have different scapulohumeral rhythm based on different people. Okay, so completely relying on scapulohumeral rhythm is wrong. If scapulohumeral rhythm is wrong, all these scapular dyskinesis is wrong. We think that scapular positioning is important. Everything is wrong. So we don't have to assess all these things. So what is this? Posture doesn't follow defined patterns. So whether scapular dyskinesis is there or not, whether you have an excessive kyphotic posture, there is no concrete evidence that there is a relationship between these two. Clear? Take home message 3. What was the take home message 1? Clinical evidence, special tests are not special. 2, don't rely on imaging. Don't rely on MRI, don't rely on ultrasound. Third one, don't keep on checking the posture. People are having different posture. Okay? Next is relevance of shoulder impingement. Okay. So Neer's impingement test you must have heard, isn't it? So he's the one who has proposed that Neer impingement test. So in 1972, he thought that shoulder pain, everything is because of the compromise in the subacromial space. Either it could be bursal inflammation or that rotator cuff tendon is getting impinged. So what he did from 1970 to 1983, he did a lot of studies and he reported that 95% of tears of the rotator cuff are caused by impingement. So any rotator cuff tear, impingement is responsible. So what he did, if there is an impingement, what they do? Acromioplasty. They cut open clavicle, they remove a little bit of clavicle, remove a little bit of bursa, they remove the entire bursa called as bursectomy, and coracohumeral arch. So they remove everything. But because of this studies, what happened is there is 746% increase in the number of surgery from 2001 to 2010. That means earlier it was used to be 2000 surgeries. Suddenly it went to 25,000 surgeries in 10 years just because of one study. Okay, it is not even a clarity, there is no evidence, but just because he has said we still follow Neer's impingement test And there are people still following this resection, acromioplasty, removing the part of acromion, removing bursa, bursectomy. But what is the evidence? No evidence. All these studies are saying that there is no evidence. No evidence. So there is no significant improvement clinically when you compare people with who undergo just exercise protocol. So again, subacromial decompression surgery for rotator cuff disease, is it okay? Let's see what the evidence says. Evidence shows that subacromial decompression does not provide clinically important significant difference. So there is no benefit over your normal rehabilitation. Subacromial decompression surgery provided no benefit over placebo. So finally they concluded, a group of people worked on it, and then they finally concluded patients should avoid surgery as there is no extra benefit from the surgery. Clear? So take home message is what? You need to push the patient as much as possible for not undergoing surgery. Just because MRI is saying that, don't send them for surgery. Clear? Take home message 5. So does shoulder impingement exist? That only we have to think. May not, because so if I do this normally, even from 60 to 90 degree there is an impingement. Usually in almost 50% of us, when we do this movement, the supraspinatus impinges with the coracohumeral ligament, okay, with the arch, okay. And people think that above 90 if you do, we tend to get more impingement, but that is not correct. So there was no difference between the symptomatic and asymptomatic subjects. Contact was maximum at 60 degree of elevation. So we think that more than 90 degrees, we get a lot of compression. No, it is not so. Because even at 60 degrees, you have a lot of compression. So we see the different distance, acromiohumeral distance, no relationship. So no relationship between the acromiohumeral distance and the pain in adults. Because before, 10 years back, we always see the X-ray. If the humerus is a little bit higher riding is there, then we'll see acromiohumeral distance is compromised. So impingement is happening. But that is not correct. Clear? Okay. So now how do people perceive different labels? So someone comes to you, you see the MRI and say that, oh, you have rotator cuff tear. Finished. There only he won't recover. He will think that he has to undergo surgery in order to heal that. Because once it is cut, patient perspective, once it is cut, he won't get healed. So it is better not to use imaging and tell him that you have this problem. Better avoid telling the patient about what problem he has. Work on him, but clearly educate him that it is going to take a lot of time. Okay? So because psychological part has a significant role on this, so if he thinks that it is going to get a problem, he's going to have a problem in the long term. So now, how do we get that? Rotator cuff shoulder pain. A lot of factors are there, kinetic chain factors, psychosocial factors, biomechanical factors, lifestyle factors. And this painful and weak, most of the time it will be weak and it will be painful. So most of the time we have to diagnose by exclusion. So subacromial impingement syndrome is as effective as surgery. Exercises is as effective as surgery. So better not to undergo surgery, number one. Subacromial impingement syndrome, exercise significantly reduces the need of surgery. If you do proper rehab, you can prevent surgery. Partial thickness tears, again, exercise is as effective as surgery. Full thickness tear, exercise is as effective as surgery. So main things what you have to consider is you have to educate the people. It can't be fixed immediately like this. So this is what happens. We think anything can be fixed immediately, isn't it? Do you think it is possible? No. All this pseudoscience comes and they feel better. Okay. So don't try this, yeah, because every season there is new concept coming, right? Each and every concept. Look into the basics, look into the exercises part as a physio. Okay, so don't follow such things. So you can't fix anything just like this. Time frame. You have to tell it, sometimes you might have an increase in the pain, decrease in the pain, but it takes at least 3 months. And after 3 months also, there may be some issues. Sometimes it resolves, sometimes with the influence of other factors like smoking and all those things, it might increase. Load management, when you are doing rehab, please make sure that you progressively increase the load, okay, and then otherwise what happen, loading will be too much and you will end up in pain. So slowly, based on the inter-individual differences, you got to progressively increase the load. Make sure that they sleep properly, no smoking habits, good physical activity, good strength, improving the strength, range of motion, mobility, everything you have to work in the rehab. So kinetic chain, as I said, shoulder, you don't treat only shoulder, you treat the entire kinetic chain. So for example, if you see the hip orientation and the shoulder orientation completely different, isn't it? So there should be some separation between these two in order to effectively perform. So X factor angle, look at this, 70 degrees. So the person in yellow or greenish, he will perform better because he can separate the shoulder with the hip. So he can generate a lot of force. So this is the difference between the elite player on the left side and novice player on the left side. Elite player have a tendency to separate the shoulders from the hip effectively, whereas the novice, he is not able to do. So his force delivery won't be that much effective. So efficient kinetic chain, one by one it acts. So the force starts from the legs, transmitted to the hip, and then transmitted through the trunk, and finally to the shoulder. So if any problem with any of the structure can impact the shoulder. Clear? So one by one it acts. It's a hip pivot, collar pivot, and a shoulder pivot. So kinetic chain, everything, all the force has to be summated, and it has to act in sequence so that it can effectively transfer to the shoulder. Inefficient kinetic chain, whenever there is a problem with other segments, it can affect the shoulder. So that is what is ineffective kinetic chain. So in an ineffective kinetic chain, it is one of the predisposing factor that increases the risk of shoulder injuries. So there is a myofascial continuum which continues from the legs. For example, the adductors, it crosses the rotators of the trunk and then it goes to the shoulder. Okay. So if you see, okay, this video is not playing, but if you see that, if you analyze this javelin throwing, you can exactly feel how the force is getting generated from the legs, through the pelvis, through the trunk, and finally to the shoulder. So it is not only the shoulder which is helpful in throwing, it is the entire kinetic chain which is helpful in throwing. So this shouldn't happen. So this will happen when there is an ineffective kinetic chain. Whenever there is a problem on one side, it's going to affect the shoulder. So here, unequal loading, right? So it is affecting one side. It shouldn't happen like that. So return to test battery, there are few batteries of test are there, like this, open chain and closed chain and kinetic chain. So only when you are able to perform all these exercises, then you are allowed to go for return to sport. But exactly what we are testing, we are not only testing the shoulder, we are testing the entire kinetic chain. So what is the take-home message? When you are testing kinetic chain, you have to train the kinetic chain. That's it. Clear? Okay. Next. So again, you're going to test the entire kinetic chain. Everything has to be stable enough in order to do a perfect push-up and clap. So you have to have a stable spine in order to get a good shoulder movement. So understood the link between the shoulder and the spine? Yes. Next. Now this is rotation. So there should be a good rotatory control between the shoulder and the trunk, because you know that the force is generated from the lower limb through the pelvis, through the trunk, and then finally to the shoulder. So that you are return to test battery, you are testing the kinetic chain. So along with that, there are a few other tests where we have to touch at different points. There are hop tests and there are Y balance test for the shoulder. Again, everything is not only testing shoulders, everything is testing the kinetic chain. So you have to train the kinetic chain in order to get it better. So training suggestions. So you have to focus on where the deficits are. For example, press, pull, external rotation, abduction. And then you have to progress one by one. Least, and then increase the load, make it a little tougher and tougher. Okay? From easier to tougher. So we have different levels of pressing, pulling, external rotation, abduction. I'll show you a few videos of that. So this is challenging, not only to the shoulder, and the humeral scapulothoracic core, but it also challenges the entire human body along with the core. So there are a few exercises. So now here you're trying to activate the musculature around the scapula just to get activation. So here you're going to do a extension with internal rotation. So now you are retracting and you're depressing, just trying to get some activation of the muscles which controls the scapulothoracic movements. So here you're activating. Along with that, you are pulling it using horizontal abduction. And now here retraction and then the depression followed by shoulder extension, everything to activate the scapulothoracic muscles. So these are to activate the different muscles of the scapulothoracic joint, because you know that as soon as there is an injury, the entire scapulothoracic muscles are going to get inhibited, especially serratus anterior and your middle trapezius. So you're going to activate that. So all these motor control exercises will be able to help to activate this. Activation exercises can help to activate that. Now lawnmower, again you see that I'm not training only the shoulder, the entire kinetic chain I'm incorporating. So whenever someone comes to you with a shoulder pain, please make sure that you are evaluating the entire kinetic chain and treat the entire kinetic chain. Again, you see that? So I'm activating the entire kinetic chain system. So this is what the ways of activating your serratus anterior. As I have said, it gets inhibited because of pain and swelling. Okay, and there are other few perturbation drills in order to improve the neuromuscular control. So normally when you lift it, it's going to be easier, but this is going to be challenging. So it will, activate your proprioceptors. So all this proprioceptive training, and you train at different planes. So now again, you see that it's not easy. You're going to activate. Can you get up, everyone? Can you try one of the movements? Get up. Get up. Try some movements. Get up, everyone. Get up. In this heat, I don't know how come you're sleeping. Get up, get up, get up, get up. Try some movements. Some of the movements what you have seen. One movement you do. Okay, do a windmill. So you do this. Feel it. Okay, so what you can do is this. Abduct it, everybody. Abduct. Abduct and external rotation of one side. Okay. So try this movement, everybody. So abduct it, abduct your legs. Yes, and then external rotate it. Can you see me? External rotate it. Okay, and now you try to take it up. Yeah, bend nicely. Please make sure that the shoulder level is in line with the hip level. Getting it? Pelvis and shoulder is in line. And try to look at your thumb. What is this called? This is Trikonasana, one of my favorite asana. Can you do that? Try the other side. Everybody, try the other side. Feel which muscles are getting lengthened or stretched. Yeah, leave some space. Abduct the limb. External rotate. Don't do a dynamic movement. Hold it there and feel the pull. Okay, feel the pull. Go down completely like this, completely like this. Are you feeling that everything is interconnected? You're getting a stretch here, you're getting stretch in the adductors, everywhere. Isn't it? So everything is interconnected. Getting it? Okay, so you have to train the entire kinetic chain. Okay, so yeah, that's all. There are a few other exercises also which we'll do tomorrow. So people who have registered for tomorrow, please come in sports outfit and sports shoes. Bring your sports shoes. Okay? And get ready, eat well and come. It's going to be a tough day tomorrow. Thank you, everyone. Bye. If you have any doubts, probably you can meet me personally, because I think now they have other work. You can meet me personally, and probably I have some other social media connections as well. So you can be in touch with me. So we'll keep learning and update ourselves. There are so many misconceptions, so many fallacies of sports medicine and sports technology and sports science as well. So we need to, come out of that. We need to unlearn a lot of things and try to learn new things so that our clients will get better, our patients or athletes will get better. All the best, young future physios. Thank you. Thank you for the opportunity. Thank you, Sanjeevan sir, and thank you, the team of our college, for giving me this opportunity. Thank you very much.
So that was Prabhuraja sir. He is an assistant professor and HOD of exercise and sports science, Manipal University of Health profession. He has given us the lecture. Actually, it was not a lecture, right? It was a talk on challenges and concepts that are related to overhead athlete's shoulder. He had started it with the evolution of human being, and it went through the biomechanics and the pathomechanics of shoulder, and he has also given you some take-home messages, which are actually the hot topics for you today. Now you have the time for discussion. If you have any doubts, you can ask to sir. Some small doubts, maybe now it's time for you. Any questions from the audience? Any questions? You may raise your hands. Any questions?
I can come there and answer your question. Those four, I saw you. I'll come.
If there is no questions, may I say my thank you to the sir? May I? Thank you, sir. Thank you for the wonderful session. Thank you.
Thank you so much, sir, for this great session. Thank you, chairpersons, for concluding the sessions. Now I invite our chairpersons to honor the session speaker to give away the memento. Thank you, sir. Thank you, ma'am. By this, we have come to an end to our academic sessions. Soon, the valedictory functions will begin. I request all the delegates to please be seated. Now, we have come to an end to the academic session. Soon after, a valedictory function will begin. I request all the delegates to be seated.